I wouldn't know.
I know, right? Okay. So my name is John Carazales. I'm an occupational therapist out of Houston, Texas. And tonight we have Whitney, who I work with. She's a speech therapist, and I'll let her introduce herself.
Yeah, so I'm Whitney Perdomo. I'm a speech pathologist. I have been in the inpatient rehab world for the last 5 years exclusively. I love working with patients who have stroke or acquired brain injuries. Although I work with a variety of patients, and I'm like LSVT certified and other things as well.
Awesome. Okay, so we shared a patient that I thought I was doing a good job with, and it took a month or two for you to call me out, which is perfectly fine because we don't learn unless we don't know, right? So I thought I was working on cognition and his ability to understand what I'm saying or whatever the case is, right? And later on this week, actually, you finally came out and said, no, you're working on communication, not cognition, right? And so
Yeah.
These types of things like visual impairments and cognitive or communication impairments are so primary in how we treat these patients, because then they can't follow our directions, or they don't respond appropriately to us, or we're not giving them the right cues. When there's so many different things, right?
Yeah, so much involved.
I know, and I don't know. And that's the problem. And so
it's abstract. It's not like having a hurt knee. It's not like having a hurt shoulder that I can visibly see the pain or you wince when I ask you to move it.
Exactly. And
Yeah.
so that's why the neuro population and the stroke population is so difficult to treat, because we are trying to figure out, well, why can't they do XYZ, right?
Mm-hmm.
And so, like, to the patient I referenced, we're trying to focus on, or I thought, right? He just came on my schedule and I was treating him. I thought, okay, there's a cognitive deficit, when really you pointed out to me that there was a deficit with communication.
Yeah, so you were really surprised when I said, his communication was severely impaired. In fact, he had global aphasia, but I believe that his cognition was more than 95% intact. The only cognitive deficit I saw was that he was just a little bit impulsive.
Right, which we label impulsive with all of our patients. It almost seems like, oh, they're not safe to go home because they're super impulsive. Well, maybe they don't understand us. Maybe they're not.
Impulsive is more of like a ability to inhibit your movements, or it's an executive function like impulse control. It's more of a judgment reasoning thing, which is that's what puts it in the realm of cognition, because things of cognition are like your ability to have alertness, to have organization, problem solving skills, having judgment, like, am I making a good choice or am I not? Can I remember the information or not? Whether it be a second, a minute, an hour, longer. And so that's why speech always says like impulsivity or being impulsive is a cognitive deficit. And communication is different, although they are often related. You have to have organization in order to put your words in the right order. You have to have some reasoning in order to choose the right words, especially when you know the grammar rules. You need to be able to plan what you're going to say for an event and know when to execute it. So there are times that cognition can be impaired and it affects the communication aspect, like the ability to formulate what you want to say. But this individual that you referenced was truly like a global aphasia. Like he had he was left-handed, so he threw things out the window on the brain mapping. So instead of his language center being dead right here, it was more, I think probably more based on his scans, it was probably more at the top, because he couldn't understand what you were saying, bits and pieces, but he also couldn't express basic wants and needs. So that's why he was truly a communication patient.
So prior to us going into cog versus communication,
Mm-hmm.
how is a OT or PT, we brush on it very vaguely in school, and we just don't get enough, right? So
Mm-hmm.
how do we, what's in a definition, what's the difference between cognition versus communication?
I would probably run through like a little bit of a communication screener, ask them a few different questions. I've got some examples for you,
Okay.
to see what the person's ability is to respond to these questions. Like how complete is their answer? Is there any hesitation? Is there any like stuttering or words that are just wrong? It kind of makes sense. You get the message, but the words aren't right. Maybe they're just really brief and you're like you just have that feeling like they're avoiding the topic.
Almost like compensating.
Yeah,
Like
like they know
they
there's a
know.
problem.
Yeah.
So now they're going to avoid the direct deficit and just get by.
Okay.
Um, so one of the things when I walk into a room, yes, I chart review. Yes, when I see that someone is right-handed and they've had a stroke on the left side of their brain, I'm thinking more language. If they're left-handed, I don't know what I'm going to see because the research in the brain is different, organized differently. But with all my patients, let's say I'm just inheriting someone's patient for the day, I'm covering someone's out sick. I'm usually going to start with like, hi, my name is Whitney. I am your speech therapist today. Tell me your name and tell me your birthday. I think it's good practice anyways to verify I've got the right person. You're supposed to have those checkpoints.
Right.
Well, I mean, that's something no matter how uncomfortable I am, whether I know you or not, I don't feel well. Those are two things I usually know they're automatic. And so you're looking for how automatic is that answer? I then say, hey, what happened? Why are you here with us? Tell me a little bit about yourself. Well, some patients, there's just going to be a hesitation. Some are going to say, oh, I had a stroke. I'm just here to get better so I can go home.
Right.
Others, I mean, if their understanding is impaired, if their comprehension is impaired, then they're going to say something probably that doesn't even match your question, like, how's football? Is there any football on today? That's just so. I was thinking maybe I should back it up and go to the 3 types of aphasia, but I can do this.
I mean, you can. It's whatever
Okay.
you want. But
I'll just roll with it. We'll just keep going through these
okay.
questions to ask. I then just because people, even if we know what type of aphasia they have, you can also evolve through different types of aphasia as you're progressing back to normal. And fatigue, like if they're extra tired this day or if they don't feel well, their language abilities can be different. So that's why I think these are good at any time.
Okay.
I usually have a patient name 5 to 10 things. I usually pick 5 things in the room, like, and on myself, like, what's this? What's this? What are these? What's this? I'm looking at their rate of response, how clear their speech is. Can they say it at all? Is it the right item?
And so what does that tell you though? Like, so I think that's the biggest point. It's kind of like, okay, they answer correctly, but it takes them 10 seconds. Like, what does that mean for us and their ability to follow commands that we're attempting to give them?
So this is just going to give you a little bit of a baseline of like when you're doing an activity, where could the breakdown be? If there is a delayed response, I would think that they need some extra time between questions, or if I tell them pick up the bar, I might need to wait for a response. Like they need to process that. They need a couple of seconds for their brain to compute that message and to respond, to pick up that bar. Oftentimes, and even as a speech therapist, my hardest thing is to inhibit myself from
Right.
again. and allowing that kind of uncomfortable quiet to let them just to see what the response is.
Yeah. And
That's hard.
based on that, what you just said, I see it all the time. It's like, um, okay, take a step with the left foot, take a step with the left foot, or come over to your left side, come over to your left side. And it's like, there might be like a 1 or 2 second period where they allow them to process that and then say it again.
Mm-hmm.
And then they say it again. And then they say it again. And I'm just like, well, they haven't had the chance to process the first time.
Yes.
And it's going to take even longer now.
You're
And
right,
so,
because it's going to bombard them. And they're
yeah,
going to have to process each repetition of that to make sure they're doing the right action.
right. I see that all the time.
Yes.
So, especially with patients that are on speech caseload, or we know they have some type of deficit with comprehension, and they just keep boom, 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 boom. And it's like, give them a second and
Mm-hmm.
allow them to process that so that they can carry out what you want. Otherwise, as a therapist, you're going to get super frustrated. And then we go to team conference, right? And they're like, they don't follow commands, they don't follow directions. It was like, well, you're not
You're not
allowing them.
facilitating.
Exactly.
You're a barrier. It's me.
Yeah. What are the barriers? Oh, me, in the way that I communicate. Anyways, yeah, so I see that a lot. But you were talking about aphasia, and did you go through the quick screen?
Well, and I mean, it does not have to be. So, speech therapist is probably going to do 10 of each of these because we like pretty numbers and quick little statistics. I would think for an OT or PT, you might just get a feeler out of asking 2 or 3 of these. Probably 3 or 4. You should have more than 2 because 50-50 can always happen.
Okay.
I would also, in the OT world, we talked about reading and writing before and how that can be impaired. And usually, okay, so we've done tell me your name and birthday, what happened, why are you here? Tell me 10 items, like name 10 things in the room or on me or something. I would add follow one-step directions, like, hey, I'm just gonna have you follow a couple directions real quick. Touch your nose. Okay, are they just gonna go like this? Are they gonna go like this?
Mm-hmm.
No, are they just gonna look at you like what? And then you
so real quick, how many
mm-hmm.
how many times should we ask that before we can solidify like a legitimate response? Like, what if they don't?
Myself and a lot of tests, even like standardized assessments, allow you to have 1 repetition.
Okay.
And so I think that's a general good rule of thumb, especially because you might also be trying to assess if they're hard of hearing.
Right.
Or if there were distractions in the room.
And another thing, while you were doing that, like touch your nose, how can I decipher touch your nose from decreased coordination? Like they're trying to, but it's like up here. So you see what I'm saying? So like, is it decreased coordination, or is it their ability to comprehend what you're saying or asking them?
So if you think it's coordination, I'd probably ask a couple more questions.
Okay.
Give them something that's not going to be fine motor, because it will be difficult to tell. I have rarely had someone who couldn't touch their nose unless they had both limbs impaired or had like a dyskinesia or something.
Okay.
Or some kind of ataxia.
Okay.
Yeah, but you could do something like close your eyes. Tell me the president's not quite so good. I've seen people use those things, but that requires a little bit of knowledge base also. So that's concrete things like show me 1 finger. Right now we shouldn't do, I guess, high five, but show me a high five. We can always fall a little short.
Yeah. Okay.
But you can try things, but it's about keeping it one step because I also see therapists and catch myself also doing it. I'll be like, okay, we're working on one step directions. Give me that ball over there. Well, just because of, whatever's on the table. Well, hand me the ball was the instruction, but over there just added something different to it. Now we added a location.
Right.
Or if I said, hand me the red ball. No, we don't need to talk about the red ball adds another element. That just made it a little harder. So if I'm just working on basic, I just really want to be concrete and direct. Hand me the ball.
So more object as opposed to defining what you're asking them, like, or defining the object.
Mm-hmm.
Okay.
Yeah, if you know that they know what a ball is, but I mean, you're also figuring out. So someone can have talking about, so those are the screening items. I would
Okay.
say, based on the response here of following directions, someone can tell there's 3 different types of aphasia. Well, there's not 3 different, there's 3 big groups of aphasia. There's like 7 total.
Okay.
3 big ones are expressive aphasia, or it's also called Broca's aphasia. And that is someone who's not able to say what they want to say or has difficulty expressing themselves. But typically, greater than 85% of their comprehension's intact. They can follow directions. They can follow like pointing directions. They can identify objects. If I'm like, where's the,
Did you?
the
Yeah.
cup?
Get your brain. Go ahead.
No, I'm saying, where's the cup? Like identifying objects from field of 2, like
Okay.
and all those things spot on. But they just can't, when I am asking them to name those 10 things, it's either they get just 1 or 2 of them. They really stutter and struggle and say the wrong thing. They may not be able to say it at all. They're having difficulty expressing themselves. Opposite of that would be receptive aphasia, which is also called Wernicke's aphasia. That's a funny word with the W. And these people are actually very fluent in their expression, but they don't understand what you're saying. You don't see this one as much, but we have had a couple in our own hospital. But these people are like the ones that you come in and you're like, hey, how are you today? And they're like, I've been looking for lunch and that TV. And they're just like, did you see Oprah? And it's like, it has nothing to do with what you said. And at first you're just thinking, oh, they didn't hear me right. And then you're like, do you have any pain today? My sock is blue and I don't know why they're over there and I don't know what's over there, but I'm here and I need to, I
I'm ready to go home.
Like, or I want to, yeah, like it just doesn't match what you're saying. Would you like some coffee? I don't know. All these people are just here. Oh my gosh, what are they doing here?
Yeah.
It makes no sense.
Okay.
There's some really great videos on YouTube that are much better than my.
I think yours are pretty good. Your examples are pretty good.
And then you have a global aphasia person. A global aphasia is going to be someone who is greater than 80% impaired for both their expression and what they understand. So essentially, they're quite dependent for their communication. And so with these kinds of people, we would really be trying to work in speech therapy. We would be working to establish their comprehension first.
Okay.
We work on their expression because you got to have a foundation to understand what people are telling you or asking of you before you can worry about matching your words to it.
So based on what you just said, that is not a cognitive deficit.
So people with aphasia, depending on the location of their stroke, they could have some cognitive deficits.
Okay.
But it is not uncommon to have a person who just has a language impairment.
How do I know that? Other than going to you or going to a speech therapist, right? How do I think a little bit,
yeah. I think a little bit could be a gut feeling where you feel like, I feel maybe it's the speech therapist in me, but I feel
Probably.
that just says something's off here. It's not
Okay.
just tell me. So I look for things in my patients like if I've met them more than once or maybe a series of times, do they recognize me? You can tell non-verbally if someone recognizes you when you come to a room. You can tell when you take them to the gym, are they familiar in this environment? Do they seem oriented to what's even going on? That gentleman that you had referenced at the start, he actually, he had reading, he had a little bit of reading skills and he understood the concept of the schedule on the board. And he figured out within 2 days, he figured out that schedule on the board and he was waiting for each of us to come.
Okay.
Like, so he had that, it was very simple reading to read a schedule when it's like 8, 10, and 2 and a clock right above it. But he had the reasoning to put those together and understand, oh, that's my schedule. Like he had that life experience of work and deadlines that was a strength for him.
Okay.
Up and dressed and ready for me at 8 o'clock. As he started improving is how I knew that his cognition was actually better than we all gave him credit for, is his comprehension was starting to improve, where he was at least getting bits and pieces of my words and like in context, he would get the gist of what I was saying because obviously I use my hands a lot to talk. I just keep going over here. But I also was writing things down for him. I was saying them, he was reading them. And we're putting some different types of communication together to increase his input. But as his comprehension improved, I was better able to tell that his cognition was intact. I'm trying to think how you would know. I think it's just gonna be some of those cues of their ability to focus and stay on task. When you show them what you've done before, maybe some familiar equipment, do they remember how to use it? Are they impulsive?
Okay.
How do they respond in that bathroom? Is what they're doing sensical? Is it natural?
And that's if it's not natural or unnatural, if it's if they kind of pause and they're trying to figure out what they're supposed to do,
Looking for prompts.
what is that deficit in? Cognition?
Yes, I would say it's probably cognition then,
Okay. And then,
unless you've given them a direct instruction.
okay. And then, as you were speaking a couple of minutes ago, there was a patient that we share, or maybe we didn't share him, but the waiter guy, right? So I figured, okay, well, I'll address, and I'll be honest with you, I knew it was some type of cognition or comprehension, but those are different, correct?
They are. Cognition can affect comprehension, but if I did not train him directly, I know who you're talking about. And that therapist had told me that he was really more cognition.
Okay. So he was a waiter. He was mobile. He was functioning everywhere in all aspects. He was independent, but he wasn't independent due to cognition slash comprehension slash I don't know. But I knew that I had to address that to even make any kind of impact with what I was doing, because weights and all of that other stuff, he didn't need that. And so I was trying to develop some type of treatment to where we can incorporate that. And I knew that he had difficulty, was it expressing or either way, I can't remember.
I think his speech wasn't very clear. I know it was not just ESL, but I think there was a little bit of word retrieval, so a little bit of expression. But I know that speech was primarily working on memory and like working memory.
Yes. And so I took that information because I went to go
Mm-hmm.
ask. I think I remember who it is, but I went to go ask who or who was treating them, and I said, "What are y'all working on? Because I need to incorporate that in my treatment because that's what he needs, not dumbbells, dowels,
Yeah.
all the other traditional stuff that we typically do." And so what I had him do, because he was a waiter, was to have him take orders from random therapists. And I think I remember memory. So he had difficulty. So he would say, "Oh yeah, I got it. Yeah, got it.
Mm-hmm.
Yeah. Oh yeah, I understand. Got it." So then we were taking drink orders. So then we went to the what
The
do you call
pop
it?
machine.
Yes,
Yeah,
pop.
the fountain.
Pop. So
I'm sorry.
but
It just
Coke,
comes
but
out.
where are you from? Anyways,
Oklahoma.
uh,
It explains everything about me that you never could figure out. I know.
okay, that makes sense now. So we
Everything.
went to go get a Coke, which means Sprite, Dr. Pepper, Coke,
Oh, that kills me.
Diet Coke,
Mm-hmm.
whatever. Anyways, so we went and he was frozen. He couldn't remember anything. And so what I thought would be a good idea was maybe, okay, have them or have him approach a therapist, ask for their drink order, write it down, and then this was later on, but write a characteristic of that therapist so that
Absolutely.
he would remember, right?
Mm-hmm.
And so he's still
It was the
kind
first
of
time he tried to memorize it, right?
right,
He didn't write anything down.
right, and because he was good, he had it.
Uh-huh.
So I said, okay, go ahead.
20 years.
Yeah, he didn't, and so then I had him write it down. Still met he got
Mm-hmm.
the drink orders wrong still, and then passed them out to the random people. And so then I said, okay, well, then let's add a characteristic of the person that you're trying to give it to. So
Mm-hmm.
attach Sprite to the brunette haired therapist or, something like that.
Yeah, pink shirt.
Yeah.
Yeah.
And so is that something that is a part of cognition or
Yeah.
memory, or is memory a part of cognition? It's
Memory
all
is
over the map.
cognition.
Okay,
Mhm.
so it's all over the map for all the other therapists except speech. And I'll be the first one to say that. And we need a little bit more understanding of, okay, they have a cognitive deficit. What is it? Other than my first response would be go talk to the speech therapist. Go see
Right.
what they've been working on. What are they doing? Can you understand what the focus is of their treatment sessions and incorporate it into yours? Yeah, and this is PT too. Like in order for them to follow your directions, or do you remember the exercise?
This is nursing, this is case management, this is
Yeah,
a diet clerk that comes in to take the menus. This is
yeah,
everyone.
yeah. And the importance of speech is so underplayed that it drives me nuts.
Oh, that's so nice.
But it's so true. Like, how else do we? That's not our strong suit. And so,
Yeah.
y'all are the biggest resource for us communicating or moving forward to with what we're trying to accomplish. Because if they don't understand, if memory is gone or impaired, we're stuck. And
Yeah,
then
so like people probably think we're robots in team conference talking about training compensatory strategies.
right,
But that's what we're doing. I mean, that's the same thing as your leg lifter and your sock aid and your other equipment. They're compensatory strategies.
yes,
That's what we're doing. So we know that like with memory, with cognition, with memory in particular, we're always training, okay, you need to write things down. That's the number one most effective strategy. You need to repeat it, whether it's out loud or by doing it over and over. We have a whole other series about like memory, but you were doing all kinds of great stuff with that person, but that person wasn't working just on memory. And the good point there, or the great point, is that rarely in our lives are we just doing one thing at a time. It's taking systems of our brain to come together. So he had to, with your help, plan, organize, remember, and execute. And those are all executive functions. I know that's another term I use a lot.
And that's a part of cognition.
And those are all cognitive.
Okay.
Mhm.
But then
If he had aphasia or language impairments, that task would have been insanely harder because reading and writing could be impaired from his aphasia.
okay, so let me break this down real quick. So
Mhm.
he was working on cognitive aspects because functionally, and how do you say it? He was able to move around fine. He was able to do everything that
he was a
the
walkie.
insurance, that the insurance scored, right? And so then at that point, they're like, oh, no barriers, he can go home.
Oh,
When-
yes.
If you send him to HEB, he's screwed. And so
Yeah.
it's like, it's just like, why do y'all not think of the whole person and think of about his interaction other than here? And it really bugs
And I
me.
feel like bless their hearts, I have to say, like, you have a lack of understanding or a lack of education in this area, because I have gotten in trouble maybe 3, maybe 4 times over my 5 years at this one place because it was stated directly to me during team conference, well, they can't stay here for just speech.
Why not?
Case manager, different case managers, and that's what they said.
And
And
that's
was not what they wanted.
that's a shame, because when we discharge people to the community and they can't function in the community,
Mhm.
are we not addressing function, period? And like you said, it's just a lack of understanding of what y'all do and what is important going forward. The problem is that they're like, oh, how are you feeling today? Oh, blah, blah, blah. And they're just like, yeah, okay, whatever.
I've had to start putting it into terms of this person cannot this person can dial 911. This person can't tell 911 what they need.
Yes, that is.
Or this person can't dial 911 or tell them what they need. Good luck with just the one-step button of like life alert. Like,
right. That is a really good example, because that's
and I've had to just start putting it in terms like that.
Yeah.
This person cannot organize their medicines effectively.
Yeah.
You know, they cannot read a medication label.
Yeah, you have to tie it more to what seems to be a more serious circumstance.
This person will not follow up with their doctor's appointments if they have to do it on their own.
Which is discharged into the community, participating or socializing in the community. And it's like, you're not hearing me. Just because they can dress themselves and walk 500 feet doesn't mean that they are free to go wherever they can and function.
Yeah.
And it's so frustrating, because I sit next to you sometimes in team conference and I'm like, did you not hear what she just said? And you just said, okay, discharge Saturday. And it's like, what's happening right now?
Are we in the same room? Yeah.
Yeah, exactly. And anyways.
That's when I have to tell them. I did go into like my splurge one time recently, and I was like, look, procedural memory is in the cerebellum. It is not in the cortex of the brain. You can retrain, like procedural memory, like if you have a stroke here, it doesn't mean that how to do things is impaired. Other types of memory are, but like that's why people do awesome when they go back into their little homes, you know, or back into their homes in a known environment. They know exactly what to do without thought.
That makes a lot of sense.
It drives me crazy. And that's how we can also retrain procedural memory by doing things 150 times. but literally like doing the same exact thing 150 times, you can retrain
Right.
that's also a whole nother day. That's why I said memory's interesting. But yes, no, I appreciate everything you're saying because I feel that there's a quality of life value, and ultimately we're trying to keep them out of the hospital, keep them from being an emergency,
Right.
them safe, and our goals are always to return them back to the community.
Nobody wants to just go back home. They want to go back home and do stuff.
Mm-hmm.
And it's like, oh, they can ambulate 150 feet. They're ready for discharge. Well, they can't put their pants on and they live alone. What's that going to look like?
Mm-hmm.
And oh, well, it's not going to look like anything because they can't even find the number to order pizza to answer the door. So that's great. Let them just walk around for no reason and not understand what's going on. And I feel like that aspect is missing generally in healthcare. Like we're not being perceived as, because all of us are PT, right? And this is not to put the PTs down, but there's so many aspects to living that is more than strength and walking. And it's like, where are you going to walk
You can get
to?
yourself throughout that store, but how do you find the bread you can't find?
Exactly. And then from a therapist aspect, is that cognitive or is it
That's cognitive
language? Or
well, it depends.
See, this is why we don't understand. And so not understanding or I know what I'm looking for, but I can't. It's in front of me, but I don't know which one it is. Or I have difficulty interpreting what I'm reading. Which one is it? That's a fair question.
That is a fair question. Or you know what you're looking for. You know it's not right there because like maybe someone took the last one or, store carries a little bit different things. And maybe you just literally only have a language impairment and just can't ask the question. Where's, like, you might even have a picture of it. Where's this bread?
Okay. And
that's language. That's communication.
Okay.
You literally just can't ask the question.
And then can you give an example of cognition based on what we just talked about?
Yeah, so I would think that person may not be at the store by themselves, but I have ran into a previous customer at HEB.
Yes.
Walking out with his Eggo waffles, and he's one that would be, he drove to that store, and if he was looking for something else, he's aware enough to know that he doesn't know where it is, and he could talk your ear off all day, but he's just confused and just leave the store without the item because he'll just forget he couldn't find it, or he's going to be lost in the store and then just leave with his Eggos.
Oh my goodness.
Mm-hmm.
That's confusing for me to understand.
Yeah, so he's either going to get lost. If it's cognitive, he's either going to get just lost in the store looking for it. He's going to maybe come out with something similar, but not the right thing. He might forget about it. He might forget the item he actually was going for.
Okay.
And I was trying to think of some other, there's probably some other alternatives here. Comes out with something completely unrelated.
But cognitively, he will not
remember to ask a person to put him in the right direction.
Okay.
Yeah, may not know how to get someone to help him with his problem.
Whereas in the language sector, he knows what he wants, but he can't express or formulate the sentence to ask for it.
Yeah, so I actually had a patient that I worked with for a really long time from inpatient to outpatient, and he would get such stage fright to speak to someone who he was not familiar with, and he had to run errands. So he would only go to the stores where he exactly knew everything that was going to be on that list. If there was going to, like, if he got to the Kroger and they didn't have that bread, sometimes he would try to ask someone and he couldn't get the words out. It'd be like a stutter and then he just gives up and just goes home without it.
And would that
Just grab
be
something else because his wife just wants bread. And she
okay?
can't realize he can't ask for help.
So would you define that as expressive aphasia or a deficit in language? Or is it-
Expressive. Yeah, he was an expressive aphasia person.
Okay.
And fatigue, anxiety, there's several different factors that can also limit your words, limit your
Right.
access to the words that you normally have.
So, for example, if PT and OT and whoever else see him before and say you see him at the end of the day, if that's a factor, they're not going to perform well for you during your session.
It could be, but I do sometimes have patients that we will strategically like kind of split ourselves to be either like first and second or totally at the end, because I tell them when you go home, whether it be cognition or communication, I do that to my patients at different times of the day because I tell them that there's different times of the day, or there's gonna be times that you don't feel great always, that you're gonna have to either think or communicate. It's just like the background noise. I like to work in the hallway.
Mm-hmm.
Like, I can't do this math in the hallway. I need to be able to focus. And I tell them, well, the grocery store and the bank and the restaurant, and sometimes even doing your bills at home because your wife is watching the TV. Like, we don't always work in perfectly silent environments.
Right.
Or we don't always communicate in ideal situations, or I'm not going to feel well and therefore be tired, but still have to go to the doctor and tell them what's going on. Like, I work in those conditions too.
Which is the whole therapeutic aspect of why you're working with them.
Mm-hmm.
Right. So
Yeah.
we want to help them through tough situations to where they can function in a normal manner.
Real life.
Exactly.
Event.
Okay. Good.
Yeah.
That was awesome. Okay, I feel like there's 10 other videos that we could make in one. But do you have a take-home point? I sprung that on you, but
Yeah, no. So a lot of times I even have to remind myself, sometimes it is okay. I mean, it's always okay. But sometimes I even need to sit back and watch my patient a little bit in their natural environment. I might do that even like as I'm passing by the dining table or kind of passing by their room, just kind of see what they're doing when they don't know anyone's looking.
right.
In the same aspect, after I give a response or give a command, I'm gonna sit back and see what's going on before I just jump in again.
So hold off on your facilitation and really give ample time to assess what's going on so that you can move forward.
Yeah, like, do they appear in pain? Do they seem as well as normal? I think with any patients who have cognitive or communication deficits, yeah, okay, I'd say that's my takeaway is like kind of sometimes we have to stop our little impulse control and stop and watch.
Okay.
But what I would like everyone to try to implement with any of their patients who have cognitive or communication impairment would be try to be more mindful to speak face to face instead of giving instructions from the side or from behind your patient or individual. Talk to them face to face. This helps them to know you're speaking to them, helps them with hearing impairment, helps them to focus and orient to the task you're doing for the intent. Provide a demonstration. Give an example of what you're wanting. Whether it's even just kind of with a pair of pants, like kind of gesturing, like, here's the pants, we're going to put them on. And like, you can't see me, but I'm like kind of doing my arms down and up my leg.
Right.
I put them on. Provide simple instructions. Just be direct. Sometimes in the South, we try to be so like, let's go to the gym and we're gonna go exercise. And like, we just try to be like, we and let's and be direct. You know,
Go to the gym.
go to the gym,
Yeah.
time to work. Just be direct. We can still be pleasant and sweet, but be direct when you're needing them to understand. And then also be mindful of what's going on around you. It might be really distracting. So maybe trying to limit the communications and the entertainment with other therapists and groups, or it might be even background noise. You might kind of test with your patients the same activities in the room versus in the gym and see if there's a difference in their response.
Okay.
Be like bombarding to their system to process.
That makes a lot of sense.
Yeah, so it's just about being more intentional with your own communication to your patient of what you want for them.
And just like what you said, I mean, that's totally client-centered. This is what they need. And that's what this whole group is about, is what's wrong? How do I address it? And how do I efficiently work that into my day? And so
Yeah.
if we start practicing better strategies and, oh, well, this is actually happening. So 20 minutes on the new step or the treadmill is actually just robbing them from 20 minutes of working on something that's actually meaningful, that will improve their quality of life. And I don't know how else to say that other than just to call it out.
Yeah.
Right? We've all done it. We've all, because we
Yeah,
don't.
it's really rote. It's really,
Yeah. Yeah, and we're better than that. But the problem is that we just don't know. And so if we can know a little bit more, maybe we can start integrating those types of processes into, okay, well, they're doing everything I'm asking you to, or they're not doing, or they're not following, or everything's so easy, they're ready for discharge. Well, maybe you're not really addressing the impairment. And so
yeah.
can we identify that?
I think sometimes that equipment is utilized to be like gives me time to catch my breath.
Absolutely.
Time maybe to organize my thoughts for that patient. Gives me time to even go get my water and go to the bathroom maybe. Not that I utilize any of that equipment or even know how to turn it on, but that's my observation. In speech therapy, I usually will tell my patients we're going to do a 3 to 5 minute warm up. If I need that transition period to, leave that last patient in my mind and focus in on you, I usually have some kind of activity on my clipboard, like a quick little worksheet or 3 things I can kind of mindlessly go through that they need, answering some questions, giving them a list of things to generate. That kind of helps me also to refocus on them, to really jump in. So like, I feel that if you need those types of equipment to do those little transitions, maybe an improvement would be to cut that time in half.
Yes. And focus on, use that time to figure out what you need to truly work on, not what else can I do? What can I use? How can I bill my time? Let's put it that way.
And even today, you can ask your patient, what do you want to work on tomorrow?
Yeah.
And that kind of gives you some groundwork.
Yeah, I totally agree. Well, I appreciate it. And
yeah.
Thank you so much. And I've been bugging you for like 2 months to come on. And I feel like there's a lot more that we could do going forward. And if anybody wants anything else, that they should comment below, as far as like, I want to learn about more language. I want to learn anything. Comprehension, cognition, is it the same thing? We need to learn more about what do y'all need so that we can help, right? And nobody knows everything. And that's why it's so important to build a network of people that know their sector and then bring it into ours to just overall improve our patients' quality of life. So I appreciate it, Whitney. And
Yeah, absolutely.
yeah, but we'll talk soon, and thank you.
Yeah. Have a good one.
All right, you too.